We'll be starting now. Very good evening, everyone, and a very warm welcome to you all. Let me begin with two simple but striking questions which we all face as a medicos while reading research papers. The very first being, how do we truly understand what the paper is trying to say us beyond the technical words? And secondly, how do we judge whether the study is reliable, valid, and relevant to us or not? These challenges most of us have faced, and today's journal club session is all about finding answers to them all. Hi, I'm Rashika, Joint Secretary of the Neuron Club, Sri Atal Bihari Vajpayee Medical College and Research Institute, and I'm delighted to be your host for this collaborative journal club event. On behalf of the organizing teams of both the colleges, I extend a warm welcome to all the students, participants, and esteemed professors who have joined us today. We're truly honored to have with us our distinguished faculty who will be moderating the sessions. We have Dr. Sushma ma'am, professor in the Department of Pharmacology, BMCRI. We have Dr. Anita ma'am, assistant professor in the Department of OBG, BMCRI. And Dr. Prashant sir, assistant professor in the Department of Physiology, BMCRI. We also have Dr. Madhvi ma'am, assistant professor in the Department of Community Medicine, SABV, BMCRI. We thank you sincerely for accepting our invitation and for guiding us through this academic session. So now let's begin with a brief introduction to journal clubs before we move on to paper analysis. So what exactly is a journal club? It's a structured academic forum, a group learning activity where students and faculty meet to critically evaluate research articles, to improve our understanding of the article, develop critical appraisal skills, and promote evidence-based practice. The main purpose is to understand how to read medical literature like a researcher and not just a casual reader, and to train ourselves to ask, is this study valid? Are the results reliable? And how relevant is it to the practice? So, why do we need it? Firstly, medical science moves really fast, and journal clubs help us to stay updated with the latest research without feeling overwhelmed. Secondly, they build critical appraisal skills. We learn not just to read paper but to question it. Like, how was the study really well designed? Are the conclusions really supported by the data and all? Thirdly, journal clubs helps bridge the gap between research and clinical practice. Instead of just reading about findings in theory, we think about how they might impact the patient care. They also give us a chance to practice our presentation and discussion skills, which are crucial for academic and professional growth. And finally, they help collaborative learning. They create a space where students and faculty can exchange ideas and learn. And an important point, this skill of critical appraisal doesn't stop in college. Later in our career, once we publish a few papers, we may be invited as a reviewer to validate other researchers' work before it's published. So journal clubs are a stepping stone towards developing that level of expertise. Let's move on to how journal clubs work. Initially, a person volunteers or is assigned to present the paper. They give an overview of the background, the study design, the results, and conclusion. But the main strength of journal clubs lies in the discussion which follows after the presentation. Everyone else participates by analyzing the methods, the questions, the results, pointing out the strengths and limitations, and sharing their own perspectives. The focus is not simply on summarizing the article, but on critically appraising it. Finally, the session wraps up with a set of take-home messages about the study, about the skills we gained. Moving on to how exactly we do critical appraisal. The way we appraise a paper depends on its study design. Different types of research requires different checklists. So here we have different checklists, like there is care checklist for case reports. There is for observational studies, which include case control, study design, cohort, and cross-sectional designs. We have STROPE, which stands for Strengthening the Report of Observational Studies in Epidemiology. For systematic reviews, we have PRISMA, which stands for Preferred Reporting Items for Systematic Reviews and Meta-Analysis. For randomized controls, we have CONSORT. For non-RCTs, we have TREND. And for quality improvement studies, we have STAR. So using this checklist, we finally understand the validity of study, reliability of results, and its relevancy to practice. So now that brings us to the paper for today's journal club discussion, Hyperandrogenemia, Polycystic Ovary Syndrome and Physical Fitness in Women, Northern Finland Birth Cohort Study. This paper will be presented and analyzed by Siri, third year MBBS student, and she is the president and of the Science and Research Club BMCRI. We welcome you to present it. Over to you, Siri.
Thank you, Rashika. Am I audible now?
Yeah, you are audible.
Good evening, everyone, and thank you, Rashika, for such a beautiful introduction. I am Siri, a third-year MBBS student at Bangalore Medical College and Research Institute. Today, I will be presenting a paper titled Hyperandrogenemia, Polycystic Ovary Syndrome, and Physical Fitness in Women, a Northern Finland Birth Cohort Study. I will be evaluating this paper based on the stroke checklist. The title is descriptive and informative. It gives us information about the study objective, which is hyperandrogenemia and polycystic ovary syndrome, with its association with physical fitness in women. This title also gives us information about the study design, which is a cohort study, and the study population, which is women from the birth cohort of Northern Finland in 1966. Coming to the journal in which it was published, the paper was published in the European Journal of Endocrinology, and this is a well-reputed peer-reviewed journal with an impact factor of 5.3 and a journal citation index of 9.9. This paper, and all of them belong to the related health departments as the Department of Obstetrics and Gynecology, Medical Research Center Ulu, and Research Unit of Health Sciences and Technology. There were no guest authors or ghost authors in the study. Before we dive into the paper, let us look at the following key terms. Hyperandrogenism, as defined, is elevated levels of androgen in the body. There is no definite cutoff as per current literature that we know. Oligomenorrhea, as given by the WHO guidelines, is defined as menstrual cycles longer than 35 days or less than 8 cycles in a year. Hirsutism is the growth of excessive male pattern hair in women after pubertal age. In conclusion, we define PCOS according to the 2023 guidelines as having at least 2 of the following criteria: oligomenorrhea, hirsutism or biological hyperandrogenism, and anti-Mullerian hormone levels greater than 3.2 nanograms per milliliter. Presently, the guidelines have been revised to include ultrasound imaging of the polycystic ovary morphology. The abstract. Now, coming to the abstract was differentiated into objective, the design methods, results, and conclusion. It was a well-structured abstract in detail telling us about the interpretation and findings of the study with effective sample sizes and confidence intervals. We will be discussing each of the headings in subsequent slides. Now, why was the study conducted? Hyperandrogenemia, as we know, affects 1 in 10 premenopausal women, and it's a hallmark feature of polycystic ovary syndrome. Androgen excess, on one hand, contributes to our traditional risk factors for cardiovascular diseases, abnormal glucose metabolism, hypertension, and obesity. On the other hand, it also contributes to the skeletal muscle tissue, the bone mass, and erythropoietin production. It thereby enhances our physical fitness. So if physical fitness is considered a very strong predictor of cardiovascular and metabolic health and all-cause mortality, then very few studies have been investigating the association of androgens with physical fitness, and they've all yielded inconsistent results and controversial results. This creates a larger research gap that the authors wanted to question. Is hyperandrogenemia that was measured by serum testosterone and free androgen index, that is a proxy for bioavailable androgens, associated with physical fitness in women? And the second question that they posed themselves was, polycystic ovary syndrome, was it itself associated with physical fitness independently of hyperandrogenemia? To answer this, the outcomes that interested in was the cardiorespiratory fitness and the muscle strength or the grip strength. Coming to the methodology of the study adopted a longitudinal prospective cohort study, and the population was derived from the birth cohort of 1966 in Northern Finland. It was a large prospective cohort containing 12,231 individuals, of which 5,809 women were present. The study received its ethical approval from the Institutional Ethics Committee of Northern Ostrobothnia Hospital in the district of Oulu, and the study was conducted in accordance with the Declaration of Helsinki. The study setting and location was clearly mentioned in the paper. The details on the data collection, how the participants were recruited and eligibility criteria and details on follow-up was also mentioned. This chart represents how this sample size was arrived at and how the people were recruited into the study. Postal questionnaires were sent out to 5,608 women at the age of 31, that is, in the year 1997, and women who answered the postal questionnaire and also participated in the clinical examination were recruited into the study. However, women were excluded if they reported pregnancy or usage of combined oral contraceptives, or if they were also excluded if the women reported usage of beta blockers, and if they were unable to complete the physical fitness tests due to impaired health status or physical injuries, etc. In total, at the age of 31, 321 women with PCOS and 766 women without PCOS were studied. The same set of participants were reassessed at the age of 46. They were excluded again if they were reported to use combined oral contraceptives, or if they were on hormone replacement therapy, or if they reported usage of Menopil. They were excluded from the test if they were using beta blockers, or if they were unable to complete the physical fitness tests due to impaired health status or injuries. They were also excluded if the testosterone levels were greater than 12 nanomoles per liter. In total, 178 women with PCOS and 648 women without PCOS were assessed at the age of 46. This was how the sample size was arrived at, and we know the answer clearly. But how was the sample size calculation done was not mentioned in the study, which is a negative point. What were the clinical variables and data that were collected from the women? Women were tested for cardiorespiratory fitness using a submaximal 4-minute Astran rhyming step test, and hand grip strength was measured using a dynamometer. Anthropometric measures such as height, weight, and waist circumference were taken. Questionnaires gave us details about the smoking status, alcohol consumption, psychological distress, and physical activity. Laboratory parameters were measured using venous blood sample collected after overnight fasting, and serum testosterone was measured by the gold standard liquid chromatography mass spectrometry method. Sex hormone binding globulin and levels, and anti-Mullerian hormone levels, plasma glucose levels, insulin, hemoglobin levels, and highly sensitive C-reactive protein levels were also measured in the plasma. The free androgen index was calculated using the formula serum testosterone divided by the levels of serum sex hormone binding globulin multiplied by 100. Homeostatic model assessment for insulin resistance was calculated using the formula plasma fasting plasma glucose multiplied by fasting serum insulin divided by 22.5. This slide shows us on the left side, we have a submaximal 4-minute Astran rhyming step test where the participant was asked to step onto a 33 centimeters high bench for 4 minutes. Sorry. Where the participant was asked to step onto a 33 centimeters high bench for 4 minutes at the rate of 23 ascents per minute. On the right side, we see a dynamometer where the subject was asked to clench the handle as tightly as possible for 2 to 4 seconds. This measurement was taken 3 times in a 15-second intervals, and the highest value was recorded as the result. Coming to the statistical analysis of the paper, several statistical tests were performed, and depending on the variable types. Yes.
Sorry to disturb. Can you wait for 2 minutes? The screen is very unclear. Maybe there is some connection issue with your side. I'll let you know again when to begin. It's very blurred.
Yeah. Okay, just a second then. I will try my connection.
Okay.
Am I good to go now?
Yeah, the screen is not blurred now. It's not blurred.
Okay.
Please continue.
Yeah. Okay. Is my voice also clear?
Yes, yes.
Okay. Thanks. So coming to the statistical analysis used in the paper, we have used several statistical tests depending on the variable types. Continuous normally distributed data were analyzed using the student t-test and ANOVA. Continuous skewed variables were analyzed using the Mann-Whitney test and Kruskal-Wallis test wherever applicable. Categorical variables were analyzed using the Pearson's chi-square test, and longitudinal data, that is longitudinal associations of testosterone, free androgen index, and PCOS with cardiorespiratory fitness and grip strength were analyzed using linear mixed model analysis. A brief information about linear mixed model analysis is that it is a kind of regression model where measurements are taken if from the same subject multiple times over different endpoints. This introduces correlation between the two measurements at different time points. And the results were reported as a beta or regression coefficient, which is the average difference in the outcome variable when compared to the reference variable. Post hoc pairwise comparisons were analyzed using the Bonferroni methods, and all the statistical data were considered significant if the p-value was less than 0.05. So, are we clear with the statistical methods that is used in the paper? Yes, and the paper did explain it really well. However, missing data on how they were handled or how they were used up in the how they were used to compare the results were not mentioned in the paper very clearly. Coming to the results of the study, in this table, as we can see, women were classified into 4 different quartiles based on the serum testosterone levels. This table compares the demographic features, the lifestyle factors, the reproductive and the metabolic parameters in different quartiles of women. Commenting on the demographic and the lifestyle factors, we can see that women in quartiles 3 and 4 were more often current smokers, and their alcohol consumption was heavier when compared to quartiles 1 and 2. This tells us that suggests a link between the androgens and also the lifestyle behaviors in such women. Comparing the prevalence of PCOS, we also see that in quartile 1, which is the reference quartile, is very low, that is 12.7 when compared to quartile 4, which is 57.2. So this was very significant in the study. Other metabolic factors such as BMI, the waist circumference, hemoglobin, and sex hormone binding globulin and free androgen index, all of them increased with the increasing levels of testosterone in each quartile. This picture, as you can see, depicts the analysis or association of quartiles of testosterone and free androgen index. To give you a very simple introduction on how to interpret these results, the results were considered statistically significant if the beta value that is expressed on the x-axis was positively associated in the quartiles. That is, it crossed the zeroth mark. Here, as you can see, in the quartiles 3 and 4, which are depicted by separate bars, were considered positively associated with the heart rate achieved at the end of the step test in both testosterone as well as FAI quartiles. However, quartile 2 was only positively associated in models 1 and 3. And let me explain you what these different models were. The model 1 was adjusted for time, the model 2 was adjusted for time, body mass index, physical activity, and smoking status. The model 3 was adjusted for time, homeostatic model assistance for insulin resistance, and physical activity and smoking status. Now, this demonstrates that hyperandrogenism was measured as testosterone and a free androgen index is associated with poorer cardiorespiratory factor because there was a decrease in the heart rate. There was an increase in the heart rate. The effect is dose dependent across different quartiles and remains significant even after adjustment. Coming to the next graph here, again on this in this graph, the x-axis represents the beta, which is a difference in the grip strength among different quartiles of women, which are depicted on the y-axis. Um, in this linear mixed model analysis, quartile 2 was positively associated in the model 1 and model 2 were negatively associated, that is, it was not statistically significant in model 3 in the testosterone quartiles. And they were all positively associated, that is, quartile 2, 3, and 4 were all positively associated with grip strength in both testosterone and free androgen index quartiles. This demonstrates that grip strength was measured in kgs by a dynamometer, but had a weaker association with it. This graph, this table tells us how women, when compared with PCOS and without PCOS, had no significant difference in either heart rate or grip strength at the end of the physical fitness test, because the p-value is more than 0.05 in both the results. So let us come to the discussion of the paper. What do we see? Hyperandrogenemia seems to have a dual effect, like we all saw. It worsens the cardiorespiratory fitness, which is a critical predictor.
Sorry to interrupt, Siri. Your slides are again a little blur.
Oh, I'm sorry. Is it better now?
Yeah, it's better. It's better.
Can you see my screen?
No, not yet. Yeah, now we can see.
So what do we see? Now, hyperandrogenemia seems to have a dual effect, right? It worsens the cardiorespiratory fitness, and cardiorespiratory fitness is a critical predictor of cardiovascular and metabolic health. At the same time, we also saw that androgens had improves the grip strength, reflecting the anabolic action of androgens. However, PCOS was independently associated because there was no difference in women with PCOS and without PCOS with either heart rate or grip strength. Comparing it with the previous literature by Bachi et al., the study showed that increase in testosterone levels was also linked to poorer cardiorespiratory fitness in women with PCOS. And this backed up our study. The second study, conducted by Huang et al., showed that administration of testosterone improved the muscle strength in athletes. And the third study showed that elite athletes performed better with higher testosterone levels. And why was this seen? This was because due to the recent studies showed that androgens stimulated mostly the glycolytic type 2 muscle fibers, which enhanced the grip strength. However, submaximal cardiorespiratory fitness tests mostly reflected the oxidative capacities in type 1 insulin-sensitive muscular fibers, and the androgens also worsened the insulin resistance, adiposity, and caused endothelial dysfunction and defect in genes involved in the mitochondrial oxidative metabolism in women with PCOS, potentially contributing to lower cardiorespiratory fitness. Elite athletes, however, were benefited because they were engaged in vigorous exercises, and whereas women in our population were mostly low to moderate mostly low to physical activity levels. This was a major difference in the study population. Coming into the strengths and limits, it was homogeneous, had a high response and a low dropout rate. The gold standard test to measure testosterone levels was used, that is the liquid chromatography mass spectrometry test. And the study also used linear mixed models, which enabled a longitudinal study design. However, there were a few limitations. The step test, which could have been measured by maximal oxygen uptake assessment using a graded exercise, was not used. Instead, we used the Astran rhyming step test, which was more feasible for a large cohort. Only serum testosterone levels, which is the main androgen in the body was considered. However, other androgens such as DHEA are also physiologically important. Other confounding factors such as nutrient intake, sleeping quality, and physical activity patterns and timing of menopause was not considered by the study. This gives us the clinical implications of the study and the research implications. Hyperandrogenemia, like we can see, is the factors and screening must be done at regular intervals to identify women with poorer cardiorespiratory factors and also at higher risk of cardiovascular diseases. Lifestyle and exercise prescription should be mostly tailored, emphasizing the aerobic training for hyperandrogenic women. In research implications, the future studies must definitely consider the option of confounding factors like cardiorespiratory fitness and grip strength that affect cardiorespiratory factors and grip strength, such as the nutrient uptake, sleep pattern, and hormonal fluctuations, and they should be studied. Genetics can also act as a factor and affects the individual's response to physical activity, and how this will be affecting our study should be done in the future. Thank you.
That was such a wonderful presentation. Thank you so much, Rashika, for the crisp explanation about journal clubs. And thank you so much, Siri, for the comprehensive presentation of the article. We would now request Dr. Anita ma'am to speak a few words on this.
Yeah, thank you. Rashika, it was a very good start to the presentation. The way you explained and the way various modes that you told us how to analyze the studies, that was very good, and that's a very apt beginning for the presentation. Siri, very good presentation. And the whole journal, actually, it is like a little bit difficult because it's a big cohort study of more than 5,000 participants, and you have done a very good job with that. And you have gone into the depth of the study, and you have understood the study and what all the components it is. And you have told about the advantages, and you have told the deficiencies of the study also, and how it can be overcome. So that was a good thing. On what is that less what is that when we had talking about deficiencies, I wish you were in the better network place, because your slides were really good, and I really would have wanted to watch all the slides. And if somebody can forward the slides later on, that would be good. Okay.
Sure, ma'am. I will forward the presentation to you.
Yeah. And certain things, I think when you're doing a journal club, no, it is about how you conduct the study is important. Certain, like, imparting knowledge there itself also can help a lot. You understand? When you spoke about what is that, PCOS, and how you measure and all this stuff, I'm sure most of you are in the beginning, like, you're learning about these things. This was a very good way to do the journal. So now if I start asking questions like how is free androgen index measured, or what is the Rotterdam's criteria, if you can just put in a little bit of all those things also and make it a more elaborate way, then it will be a very comprehensive way. Like, the person who attends a journal club will go out not only with the idea about how to conduct a study, but also they will have another extra knowledge about knowing everything about PCOS. Okay.
Yes, ma'am. Sure.
Yeah, so it is a very good study. What made you select this study?
Ma'am, I was reading a few papers and I thought this journal would be good if I can present it as evaluate the and critically appraise this paper.
Okay. Okay, but you would have read other papers also, no? So what made you decide on this?
Uh,
See, whenever you
Ma'am, this
go into a research, right, the first question is why this topic, why this study, why this, what is the need for this, everything, the entire research, right? Even if you are doing papers, right, then it should start with a why. So that is why I'm asking you.
Ma'am, I was actually reading articles on PCOS for my
Okay.
research, and this paper I
Okay, so
found out
okay,
was
PCOS was
really
your area of interest.
yes.
Yes, because it's now affecting the population in a big way.
Yes, ma'am.
Yeah, okay. Very good. Very nicely done. And very nicely organized, Rashika.
Thank you, ma'am.
Yeah.
Thank you, Anita ma'am, for your kind words. Madhvi ma'am, over to you now.
Yeah, good evening, everybody. I'm Dr. Madhvi, Assistant Professor, Department of Community Medicine, Shri Atal Bihari Vajpayee Medical College. Firstly, Rashika, it was a very good presentation for the start of the journal club. You told exactly what needs to be looked out in a journal club and how are the various modalities. One more slide I would have for the next session. What you can add is you can add a slide on levels of evidences. So in that context, if you add a slide on levels of evidences, one will see what are the levels, different levels, and which is of the highest quality. Because we all know that it's a era of excess of information, right? So what to choose, what not to choose, and which will be a better quality study will be adding on to the knowledge for the existing. So that one slide you can add for the next session. Coming to Siri, it was a very good presentation. You have got into a depth of the analysis of the critiques of the article. However, I would like to add some one or two points. Suppose, for example, the study is a cohort study and it is well designed, but however, there is some lack in the sample selection, right? As you rightly mentioned, the sample size estimation is not mentioned, very right. And however, the group selection, what they have selected for comparison is not same as well, right? The PCOS group is smaller compared to the other group. When you apply certain statistical test as well to nullify that, but it will not be of that much effect. So the similar group selection would have been more efficient. And one more thing, for the exclusion criteria, they could have excluded migratory population, right? So it's a cohort study for a longer period of time. If there's a migratory population, they'll have their own genetics, they have their own eating habits, their own sleeping patterns, and other things which can add up as a confounders. So most of the confounders they have tried to eliminate, correct? So, but however, the migration factor could have been a very big confounder for the results. Whatever they have applied. And one more thing is, as you have already rightly mentioned, they have not gone for gold standard test of VO2 for cardiopulmonary functions, which could have added a better evidence. And one more thing I would there is something missing for me for the analysis is they have divided into 4 quartiles for analysis, right? So they have enrolled at the age of 31 and they have finished at the age of 46. I would like to know the numbers in each quartile, the frequency, right? So how many people actually were in the first quartile, how many people, that would have given me a complete picture of the analysis, knowing the percentages. So that would have added little more depth for me, or at least a mention in a line or two for the statistical analysis. So that would have added more weightage, the frequencies of those 4 quartiles distribution. And other than that, it was an excellent kind of a review. Only these factors, they could have added more weightage to the paper. That's all from my side.
Thank you so much, Madhvi ma'am, for your
Yes,
thoughtful suggestions and valuable additions that you've made. Thank you so much. I would request Dr. Sushma ma'am to say a few words. Oh, looks like ma'am has joined now. Ma'am, Sushma ma'am, I would request.
Siri, is Prashant there in the group?
Ma'am, I don't think sir has joined.
Just check, no? Give me 2 seconds. I started driving.
Yeah, and one more thing, as Dr. Anita Madam rightly asked, why did you select? I would like to ask you, because it's a Finland study and the generalizability for the Indian population is, I mean, in that context for all the population of the world is a little bit difficult. And so you can go for any more comprehensive based study or more relatable study to the Indian population in that matter.
Yes, ma'am.
Yeah.
Regarding that, I was actually reading up on two different topics like PCOS and aerobic exercises. So I came across this study and found the study was, clinically
no doubt, it's
very
a very good
significant.
study. No doubt it adds to the knowledge, whatever is there. But being a Finland, the generalizability of the population of this study as a critique. So you can mention the generalizability of the study results to the other population or
Indian population.
other ethnicity population is of limited value. So that
yes, ma'am. That is one limitation
yeah.
of the study.
Yes, that can be there.
Because in India, most likely PCOS we diagnose is basically on the clinical features. Because most of the patients they are not we cannot do FAI, we cannot do DHEA levels and all those things.
Yes, ma'am.
So this study had a lot of those components. No? So like how Madam told, the you how you extrapolate these results into our population, that also you have to see.
Yes, ma'am.
Yeah, yeah.
Siri, am I audible?
Yes, ma'am.
Uh, can I speak now?
Yes, ma'am.
Okay, and congratulations to both Siri and Rashika. I think this collaborative thing was very nice, very aptly presented by both of you. Um, and then I think Anita and Dr. Madhvi, I think they have really summarized all the comments, and I'm not very sure what is left for me. But anyways, Siri, it was really wonderful. You have analyzed everything, and then you added a little bit more on stats also. So as Anita already told you, you have to start adding in a little bit of theory parts of it, and also just to say whether this cohort study design is the right design for the study. So things like that you can start adding in. And then coming to statistics, you put up a table saying that continuous variables were done by student t-test and then ANOVA and things like that, right? Siri, you can hear me? Hello?
Yes, ma'am, you're audible.
Okay, right. So when you
Yes,
put up
ma'am.
the table, I think
Yes, ma'am.
you have to show which are those
Ma'am, you're audible.
continuous variables. Yeah, which are those continuous variables, and then show us where student t-test was done, where ANOVA was done. So after ANOVA, why do we do a post hoc test? And what does that significance tell us? And you can put in a little about what is linear regression, which is the independent variable, which was the dependent variable. Okay, and then what was the reason? This is a mixed model. I think you sort of gave us an introduction, but you can always say what was a fixed effect model and a random effect model, little, very much little, and give them the link for videos before the journal club itself to see a little bit and come. Okay, so lots of times when we are doing research and writing articles, it is the statistical tests where we go a little wrong, and then the whole result becomes wrong. So I think a little emphasis on statistics is required from the beginning of your journey itself, so that by the time you become postgraduates, you know what is right and what is wrong. And then one more point I wanted to tell you is, when you conclude the paper, please go back to the objective and show us the objective again, or put up the objective there, and you just tell us whether objective and the conclusion is in line. Okay, so what was my objective to start the article, and whether that author has really concluded based on his objective. That is the place where majority of us want to conclude a little differently, and we would have forgotten what our objective is. So that's one comment you always have to add. And from next time onwards, please, when you show the results, you say that this is a continuous variable, and student test was done, and this is the p-value, and these are the categorical variables. This is where the chi-square test was done, and this is the p-value. And when you look at the p-value, how will you interpret the chi-square test? So if you start adding that, I think if that culture starts, I think it will be really great in analyzing the papers. Otherwise, a fantastic job uh, being students, and very well analyzed. Both the speakers were very good. Okay, thank you.
Thank you, ma'am.
Another thing, like as a clinician, I'm really telling you, Siri, even our postgraduates may not have presented it this well, and I'm really like appreciate this initiative. Because research, we don't place so much we used to not place so much value on that, but very nicely done, very good initiative, and very good efforts.
Okay, I think now we'll open the floor for your questions to the audience. You want to add on any points, any thoughts, any questions? Please feel free to raise your hand and unmute yourself, or you can also put it down in the chat box. Okay, I think there are no questions. Is that so? Or is anyone typing? Okay, I think that was really clear for us to put in any questions as well. Okay, with this, we will come to the end of the session. And I would like to thank each and everyone who joined this session. And thank you so much for making this collaboration between Science and Research Club of BMCRI and Neuron Club of SAB such a grand success. Special thanks to our presenters, Siri and Rashika, for their clear and insightful presentations. Also, special thanks and heartful gratitude for our moderators, Dr. Anita ma'am, Dr. Sushma ma'am, and Dr. Madhvi ma'am for joining us. Your presence really means a lot for us. Thank you so much for the audience for staying with us throughout the session. And with that, I would like to conclude today's Journal Club meet. Thank you once again for your active participation. We look forward to see you in our future sessions as well. Have a wonderful evening. Thank you.